Hello everyone, my name is Pavel Jankowski. I'm a neurosurgeon, practices here at Hoag and at Children's Hospital of Orange County. My focus is on spinal deformities, scoliosis, and complex spine. Today I'll be talking to you about caring for your back, surgical and non-surgical treatment options. We have a lot of material to cover, so we're going to dive right into it, and I welcome you to send any kind of questions throughout the course of the talk. So we'll be going over degenerative conditions that affect the spine. We'll be talking about the anatomy of the spine and surgical along with non-surgical treatment options. So what are degenerative conditions? Simply put, these are the snackle, crackle, and pop ears that occur as our spine is a biomechanical wonder. However, it's not immune from the wear and tear that happens to any kind of device that has motion in it. And therefore sometimes needs tune-ups, adjustments, or replacements. So what happens during this aging process? We have here on the left-hand side an image of a pristine spine that we start off with. We can see a capacious spinal canal. We can see the nice square vertebral bodies, and in between them healthy discs that are well hydrated. And over time, through wear and tear and also genetic factors, we see what happens to that spine as we age. Primarily this starts with a flattening of the lumbar discs as they lose their hydration content, which results into a loss of height, results also in protrusion or herniations that then lead to obstruction of the spinal canal, resulting in different symptoms. Causes of these degenerative conditions account from two primary factors: genetics and also lifestyle. If we were to take a cohort from the general population and image their spines, we find that 90% of people over the age of 60 have degeneration in their spine, especially their discs. Based on well-known twin studies that were conducted in Australia, Britain, and Europe, it was shown that the heritability of transmission of degenerative disc pathologies and other conditions of the spine ranged from 34 to as high as 74%. The degenerative conditions that we'll be covering today include facet arthrosis, herniations of discs, stenosis, central and foraminal, spondylolisthesis, and adult degenerative scoliosis. First off is degenerative discs and facet arthritis. So here we have a nice artist illustration of the spinal column showing the lower aspect of the thoracic spine along with the lumbar spine. And starting from the very top, we see a healthy disc which has a nice rectangular architecture, a spacious foramen at the top for the spinal nerve to exit out of. And we have the different conditions that happen to the disc as it undergoes degeneration, to subtle flattening, to bulging, to eventual herniation, and an entire collapse of the disc that leads to a bone-on-bone phenomenon, which is quite painful, resulting in compression of the spinal nerve, along with significant arthritis that is illustrated here on the right-hand side when the cartilage, it dissolves away and you have bone rubbing against bone. These symptoms are attributed to the pain that is experienced. The pain typically that results in arthritic conditions of the spine are localized pain, if it's in one area more than another, or a regional pain distributed in this map here, where if the pain originates from the cervical spine, it can be referred to the base of the skull down to in between the shoulder blades. Along in the lumbar spine region, if the pain originates from that area, it can be referred down to the buttocks, the hamstrings, and in the anterior part of the body to the inguinal region, anterior thigh region, and lateral thigh region. The sources of this pain are from free nerve endings and mechanical nerve receptors. In terms of the innervation of our spine, it's the outside of the discs that have innervation. They're provided by the sinovertebral nerve, and the inside of the disc doesn't have any type of innervation. In terms of the joint spaces, they're innervated off of small nerves originating off of the spinal nerves that then respond to direct pressure, distension, and inflammation processes. This then also affects how the muscles interact with the joint spaces, resulting in spasming of these muscles, causing tightness, of the erector spinae, the psoas, the paravertebral muscles, and the multifidus muscle. In terms of the treatments, how we think about it is the best and easiest way is to imagine this as a pyramid scheme, with the conservative treatment measures being the most available to patients at the bottom, consisting of non-operative treatments, tapering off at the top to surgical treatment options. In this first tier, we can see here some well-known treatment options that have been employed probably by many of us in the past, which involve from being the most conservative of resting and modifying our activity, icing and heat, non-steroidals, muscle relaxants, short course of steroids, altering our eating patterns to lose weight, physical therapy, massage, acupuncture, chiropractic, except in the cervical spine. The reason I say this is that in our cervical spine, we have two very important arteries that perfuse the posterior part of our brain. And typically, during certain chiropractic manipulations of the neck, these vertebral arteries can be damaged, resulting in dissection, which then leads to stroke. The second mode of treatment, a little bit more invasive, involve injections. These consist of facet blocks, which are incredibly helpful for the clinician and the patient, since they can not only be therapeutic but also diagnostic in helping us to hone in on which part of the lumbar spine, cervical spine, thoracic spine is resulting in the pain and symptoms, to medial branch blocks, neurotomies, or nerve ablations. Finally, we have at the topmost tier, we have the surgery. Indications are various. However, I have listed here the indications that I use in my practice, which consist of uncontrolled pain that has been refractory to the conservative treatment measures for more than 6 months. If a patient is suffering from adult degenerative scoliosis, which we'll touch upon here in a bit, neurological deficits that are progressive or not improving with time, failure of conservative treatment measures as a whole, and radiculopathy that has been persisting for more than 6 weeks. Next topic, it will be disc herniations. Here is a nice artist rendition showing us the disc. In the middle, we have the nucleus pulposus. This acts as a shock absorber. On the outside, we have a firm structure wrapped in type 1 collagen, which consists of the nucleus fibrosus. This is meant to resist axial rotation from side to side and tapers off towards the back portion of the disc and is more prominent towards the anterior portion, creating a wedge-shaped structure, which in turn also influences the shape of the spine. 80% of the disc is comprised of water content, which is also one of the reasons why in the later years with degeneration, there's a loss of this water content, which is the first indicator of degeneration. The discs account for 25% of the spinal column height and is therefore also the reason why we tend to decrease in height as we age. This results from that degenerative processes. We can see here again from the figure outlined previously the different transformations that the discs undergo in their degenerative timeline. Here is a schematic showing us what happens when the outer layer of the disc becomes violated through these degenerative processes and there's an extrusion of the inner material, the nucleus pulposus. Depending on the location of this herniation, it can also result in various symptoms. This can lead to a central herniation, which will compress the spinal cord centrally, or it can lead to a lateral herniation of disc material, which will affect one nerve and therefore one muscle region, resulting in shoulder, arm pain, buttock, leg pain, or the common sciatica. Also numbness can be associated with this, loss of a reflex, or muscle weakness. Here in this MRI, we see a patient that has a healthy looking disc at the L3, L4 lumbar vertebral region, and we can see this nice water content on the outside. And as we move downwards to the spine at the L4, L5, and L5S1, we see the degeneration progressing to a slight protrusion of disc material to a herniation. Incidentally also, this is the most common area where pathology happens in the lumbar spine because 60% of motion is attributed to the L4 to S1 region. And as previously stated, any part of our body that has motion is prone to degeneration. Therefore, a lot of different types of diseases in the lower back arise at these two levels. And then on our right-hand side, we see an MRI picture of what this looks like in a cross-section where the herniation is impacting the nerve as it's exiting out. For this pathology, again, the same type of hierarchy and pyramid scheme applies for treatment, starting off with the non-operative treatment measures previously discussed. Next, we have steroid injections. The difference here is instead of targeting the bone, we are targeting in particular the nerve. And so this is where transforaminal steroid injections are used. And the whole point is to try to distribute the medicine as near to the nerve as possible without obviously impaling the nerve or directly touching the nerve. In terms of surgery, the indications, again, are primarily uncontrolled pain, major or progressive muscle weakness, radiculopathy for 4 to 6 weeks that has not responded to conservative treatment. And finally, the two last ones are probably the most pertinent and also urgent to act upon. The first is cauda equina, which is a conglomeration of symptoms that include saddle anesthesia, weakness in one of the lower legs, sensory loss, bladder dysfunction, also can be attributed with incontinence of stool. This is a surgical emergency and needs to be addressed within 24 hours. The next involves myelopathy, which is most commonly found in the neck and the cervical spine. This also is a collection of different symptoms that is progressive, and unless the spine is decompressed, will continue to progress and cause symptoms. These include dizziness, especially when extending the head and looking upwards, closing down the diameter of the spinal canal. These can also include lack of coordination or decreased coordination with the hands. People will say that their handwriting has worsened over time. They'll also endorse difficulty opening jars. Some will say that their hands tremble when they're holding their coffee cup, to even people dropping cups or plates. In addition, there will be sensory symptoms that will be attributed with this and frank weakness. If this is not treated surgically, the symptoms are irreversible. In terms of the goals of disc herniation surgical treatment is direct decompression. Again, there is a pressure on the nerve. The whole goal here is to decompress that nerve in order to stop the symptoms and return the nerve to a normal function. In terms of treating a generalized pain, we discussed this in the previous segment, that's associated with the facet arthritis. Next up is spinal stenosis. The key point here is to differentiate between what is a central stenosis versus a foraminal stenosis. We can see here on the left-hand side a diagram of a healthy looking cross-section through the spinal column, where we see the spinal cord, the spinal nerves coming off, traversing through the lateral recess that is open and out through the foramen. On the right-hand side, we can see here direct compression of the spinal cord through protrusion of the disc that is effacing the ventral portion of the spinal cord. We can also see degenerative changes, hypertrophy or thickening of the ligament that overlies the spinal cord. This is known as the ligamentum flavum. Next, we can also see degeneration in the joint spaces, which is a spiculing type of appearance that will happen. And due to the atrophy and loss of cartilage at the intervening joint space, this will create a painful bone-on-bone phenomenon. Neurogenic claudication is associated with central stenosis of the spinal canal, and this leads to pain, tingling, numbness, weakness in the buttocks and back of the legs. A sensation of heavy legs is associated with this that patients will commonly endorse. Difficulty walking longer distances. Sometimes people will complain that they can't even make it from the car in the parking lot into the store. Bending forward will alleviate this, and therefore patients will say that when they sit down or when they stoop over a shopping cart, the symptoms improve slightly. Here we have MRI picture showing a degenerative discs from L3 to S1 causing compression of the spinal canal when we look at it from the side. And then in the cross section, this is an image of the same patient and pointing and the same type of features that were described in the cartoon previously, we can see a thickening of the ligamentum flavum. We can see extrusion of disc material compressing the spinal cord. We can see closure of the lateral recess and the foramen as the nerve traverses out. And we can see degenerative changes in the disc. Compare this to the left-hand side of a healthy-looking cross-section. We see a spacious lateral recess and area for the nerves to traverse out on the right and left-hand side. We see a nice circular shape to the spinal cord. We see also no protrusion from the disc. Again, let's go over the difference here between central and foraminal stenosis. On the right-hand side, we see a foramen that is open. This is what's happened when there is sitting or bending forward motion. And we can see that there is ample amount of room for the nerve to traverse out. On the left-hand side, when we extend ourselves in the lower back or we're walking, we see a closing down. In a healthy spine, this is not a factor because there's enough room without compressing the nerve for the patient not to experience symptoms. However, you can imagine as that disc begins to flatten and eventually erode itself to being non-functional, the space becomes so tight that there's direct compression on the nerve, causing foraminal or radicular symptoms. This is an example and diagram here of what happens when a patient is standing or walking and they start to experience leg pain along with weakness. The shopping cart sign is associated with the patient bending forward in an attempt to open up the spinal canal space and increase the room and pressure off of the nerves. Also, when a patient sits down, the same thing happens. Incidentally enough, when we sit in a relaxed posture on a couch or in a chair and slouching our back, we actually are in a greater flexed position than if we would even bend forward. The moment we try to extend our spine and sit up, we will close down that space, therefore triggering symptoms. In terms of treatment, again, the same type of pyramid scheme applies to non-operative treatments. When there is direct compression of the nerve, a medication that is commonly employed that has been around for a long, long time is gabapentin. Many patients may have heard of this medication. Also, they're well aware of its side effect profile. However, it is an effective medication that is employed and can help with some of the symptoms. In terms of injections, steroid injections, again, are meant to target the nerve if it's being compressed in the foramen. If there is central compression of the canal causing neurogenic claudication, then there has to be a direct decompression. Therefore, indications for surgery are uncontrolled pain, progressive neurological signs, radiculopathy, or cauda equina, which again mentioned is an urgent surgical indication. Spondylolisthesis. So it's a long word, but to break it down, essentially, listhesis is a slippage. This can happen in the forward direction. It can happen in the backwards direction. What ends up happening here is a closing down of the foramen and blockage of the nerve as it's traversing out, but also something that commonly does not go, that goes unnoticed and is not discussed, is that there is a tugging of the nerve. And it's this tugging of the nerve that can create the most painful symptoms. And it's something that also needs to be stopped. Therefore, symptoms, depending on where this happens, can be associated with the shown on the screen. Most commonly, we see this in the lower lumbar spine region at L4-5. This can be attributed to direct trauma. This can be also attributed to microfractures that happen earlier on in life and then progress as a person ages, to eventually leading to complete failure of the pars intra-articularis, which is a portion that connects directly with the facet joint to where the fracture becomes so great that there is instability and the slippage happens. If there is sufficient space at the foramen, then the patient can be asymptomatic and this can be washed. However, if there is associated neurological symptoms or progressive pain that is unresponsive to conservative measures, surgery is indicated. It also is important to note that this is one of the few conditions that we have good clinical evidence that with surgical treatment, restoration of alignment of the vertebral bodies, patients do incredibly well after surgery and have a quick return to function. So as mentioned here, we'll skip over the more conservative measures since they're similar. In my practice, typically when patients come in with this, they have already been through the conservative treatment pyramid scheme and have not seen an improvement, and at that point I counsel them for direct surgical intervention, since again the data is very favorable in this condition and they can have a return to function in a rapid pattern. Case in point, I've had several patients over the years that have come into my office on wheelchairs. The day after surgery, they're up and walking. The last condition to discuss is adult degenerative scoliosis. This is something that is becoming more and more prevalent in our aging society. And here we have a nice schematic of our postural evolution that happens from the cradle to the grave. Also, we may have heard this throughout our lives, posture does matter. So it's important that we don't ignore this, and especially in our developing world, in our developed world, where a lot of the time is spent sitting in front of a computer screen. This has direct implications on our level of pain that we experience in the neck and lower back. As far as what is involved here, let's just start quickly from the basics. The spine has an S-shaped. It has 3 types of curvatures. There are specific reasons for this, starting most at the lower aspect in the lumbar spine, where there is an arch. This we call a lordosis. Traversing upwards into the thoracic spine, we have a hunch forward, which is a kyphosis. Purpose of this is for our expansion of the lungs. Finally, traversing up into the cervical spine region, where there is again an arch or a lordosis to counteract the kyphosis in the thoracic spine. We can see here on the diagram that the center of gravity is meant to be that the head is directly to be positioned over the pelvis. So if we were to draw an invisible plumb line through the center point of our body, our center of gravity would flow directly through the soles of our feet. If there is an alteration in this spine shape, the center of gravity will shift. Typically, this shift is in the forward plane. And with degenerative changes that come on later in life, affecting the lower back and the lumbar spine region, where there's a flattening of the discs, leading it to a flattening of the lumbar spine and alleviation, not alleviation, but a distortion of the lumbar lordosis, this will lead to the center of gravity shifting forward. In doing so, a host of other symptoms then will manifest. This is a very good diagram showing as we age what also will happen to our posture, going and imagining that S-shaped curvature that I spoke of earlier, where we can see here, starting off on the most left-hand side, we see an arch in the lower lumbar spine, then also a straight straight-necked or an arch, and then as we age, we can see a flattening of the lumbar spine to an eventual hunching and loss of lordosis and prominence of a kyphosis in the thoracocervical region. The cone of economy further helps to illustrate this point. This was developed by a French surgeon, Claude Dubussy, and the tenet of this principle, again, is that the body is at equilibrium when the head is positioned over the pelvis. If there is a deviation away from this cone of economy, a host of symptoms will then start, and there's a cascade of events that will eventually lead to pain. The causes of degenerative scoliosis are many. However, most commonly, this is associated with aging, and phenomena such as arthritis and osteoporosis. And also, in addition, we have loss of muscle mass, which is something that has been ignored, and only in the past 5 years is being given more and more attention in the medical literature. As we age, especially after the age of 60, there is fatty infiltration, especially in the lower lumbar regions of the spine, which is more prominent in women than men, which leads to a dysfunction of these muscles that again consist of the erector spinae, the multifidus, the paraspinal, and psoas muscle. These muscles have a very important role in maintaining the correct posture and helping the spine maintain its curvature. When there is a loss of this, a lot more forces are then transmitted to the joint spaces, the discs, which lead to accelerated degenerative changes. When taking a gross analysis of adult scoliosis patients and looking at quality of life outcome scores, such as the SF-36 scores, and comparing it to the general population, we can see here the red columns represent patients with adult degenerative scoliosis, and the yellow columns represent the general population, that patients suffering from this score significantly lower. This not only ranges from physical functioning to pain, to general health, vitality, but also impacting psychological and emotional health. In terms of the scoliosis, many times in the general public, people think of the adolescent idiopathic scoliosis, which is shown here on the left-hand side. However, what happens is the picture here on the right. Through the degeneration, flattening of the discs, arthritic changes that the spine undergoes in later years, we see the curve here that then forms on the right-hand side. The common symptoms of this are typically pain. Pain that has not been able to be treated successfully with conservative measures such as exercise or injections. Also, there can be neurological symptoms, so painful paresthesia, sciatica, weakness, sensory loss can also manifest. Non-surgical treatments, and one of the best defenses for this is to remain active. So maintaining a healthy lifestyle, participating in physical therapy or group therapy exercises, core muscle strengthening, something that has not really been a tenet of our physical therapy and exercise paradigm until the last decade, is one of the best defenses against this. As far as pain injections, the same type of paradigm applies to what I spoke to previously. These can range from neuroforaminal blocks. They can also range from facet blocks to nerve ablation procedures. As far as surgical indications, they're similar to what we talked about previously. And in my practice, the first patients will undergo an extensive conservative therapy paradigm before they are triaged into a surgical protocol. Surgery for this has changed drastically. This is one of the areas in spine practice that has been significantly impacted by advances in technology, to where about 20 years ago, this was sort of the surgery that you heard your relatives and friends speak of not to get, to now where we have the OR here shown on the top right-hand side. We have had advancements in ability to monitor patients during the procedures. We've had technological advances to help us visualize the spine while we're doing these procedures. All of this leading to very effective, safe, and successful outcomes. Here's a picture demonstrating this in full detail. This is one of my patients who presented with a cervical thoracic deformity that was also experiencing myelopathy. We can see here the preoperative images shown on the left-hand side and his standing x-ray, to the postoperative images after successful surgery and alleviation of the myelopathy. Here is another one of my patients. This patient received surgery at an outside facility and was unfortunately fused in a position that he could not straighten from. We can see here the orientation of his head. He was frustrated that he was constantly looking at the world with inability to look up, and we can see the postoperative images here on the right-hand side after his correction. So let's now delve into a little bit about the minimally invasive strategies and the advancement that have happened over the past 10 years to 20 years. So starting off, the advantages of minimally invasive surgery are ones that you may be familiar with already. These include less soft tissue destruction, less blood loss, less pain, fewer infection rate, shorter hospitalization. Here's a diagram showing us a general picture of what this entails. This is an endoscope or tube that is positioned into place over the appropriate spine segment for the surgery. We can see here that the tube traverses the muscle planes and tissue planes without disturbing too much of the area. This is also the same type of picture showing a surgical tool that is meant to be removing a portion of the bone to relieve the pathology that is accessed through the endoscope. Here is a picture of a patient on the OR table about to undergo a decompression of a nerve. And we can see here the endoscope being positioned over the appropriate segment. This is a good schematic showing us the difference, and probably the most telling difference between what is an open procedure and a minimally invasive procedure. We can see here in A the different types of components comprising of the skin to the subcutaneous fat layer, fascia to the muscle layer, finally to the spine. In B, we see the retractors that are used to push aside these tissue planes and muscle to expose the spine, and see the bony anatomical landmarks. And in C, we can see percutaneous pedicle screws that are used to traverse these planes without disturbing the muscle and tissue planes. This is also a view of during a patient undergoing a similar type of procedure where there's a fusion being performed, and we can see the small cuts through the skin, the different percutaneous pedicle screws that are extending out through the skin, again, with little tissue disruption. And a post-operative image showing here an inner body that was placed at L4-5 with pedicle instrumentation at L4 and L5. The next wave that has been one of the greatest advancements in spine is computer-assisted navigation and robotics. In the 90s was the inception of computer-assisted navigation, with the purpose being to improve surgical accuracy and reduce radiation exposure and increase surgical safety. As far as comparisons between open procedures that were done by freehand, we can see here that using conventional minimally invasive techniques, utilizing fluoroscopy, there was a 13.1% breach rate or inaccuracy of placement of percutaneous pedicle instrumentation. Then when compared to 3D computer-assisted navigation, this dropped to less than 1%. Existing computer-assisted navigation platforms, this is a brief slide outlining them. Many of them have been around for more than a decade. The newest kit on the block is 7D Surgical, which utilizes a novel technological innovation. Here is an example of one of the oldest computer-assisted navigation systems. This is the Arrow. We can see here the patient laying on the operative bed and the scanner that can glide over the bed in order to show intraoperative imaging. This has been around since 2013. It enables us to get a 360-degree scan while doing the surgery, and afterwards to assess placement of any kind of instrumentation. This is an image of the 7D Surgical, which utilizes 7 cameras. It has non-ionizing radiation and has the same type of technology that is used in self-driving cars, such as Tesla automobiles. This is an intraoperative photo of the 7D in use, where the surgeon has a full rendition of the anatomy and is able to maneuver the surgical tools, and that allows for placement of any type of instrumentation. This enables the surgeon to at all times have an augmented reality view of the patient's spine, again without any radiation. This is an image from one of my photos. One of my patients from a previous surgery. You can see here on the left-hand side a 3-dimensional reconstruction that the software formulates, then to intraoperative images that are attained. This is just a workflow slide showing again how fast this is, that the average time frame for registration is on the order of 88.7 seconds. And this is a planning software that is utilized. This is one of my adult scoliosis deformity patients that was operated on using the 7D machine. We can see here the blue line where the patient's spine should have been. He is right now out of alignment with the center of gravity anteriorly displaced, and we can see after the surgery on the right-hand side where he has been brought back into alignment. In terms of percutaneous technology that the 7D offers, this has been the latest innovation in this technology. Unlike previous percutaneous minimally invasive technologies that relied heavily on fluoroscopy and continuous radiation exposure to the patient and the operating room staff, the surgeon here has again full augmented reality view of the patient's spine that allows them to safely and effectively place any kind of instrumentation and perform the surgery. In terms of robotic surgery, this is sometimes that I get many questions about. This has been around for a little over a decade and is also something that continues to evolve. One of the biggest advantages of robotic surgery has been that the surgeon is able to plan the surgery ahead of time and where they're going to place the implants. It also allows for active navigation, so just as one would imagine where there's a robotic arm that's actively maneuvering, this is exactly what happens. If we compare this to other existing types of surgery, such as the computer-assisted or freehand navigation, we find that the accuracy is on par, ranging from 85 to 100%. However, time and length of these procedures is longer. Here's an image of the Mazor Robotics X, which we have at Hoag. Mazor has been in this line of work the longest. They have logged the most cases in the country. This is a platform that allows for the surgeon to plan the procedure ahead of time, to also be able to see how the instrumentation and procedure will look like after. The robot aligns itself where the surgery should take place, and the surgeon then performs the rest. As far as difficulties or failures, again, this is a evolving technology. One of the biggest sources of, I would say, trip-ups or hurdles is software issues and failures, which lead to increased operative time. Also, inability to achieve certain angles depending on the patient's anatomy, which is caused by limitations of the robotic arm, and skiving, which is meant slippage off of different types of tricky, bony anatomical landmarks, which can lead to misplacement of the instrumentation. Finally, to sum it up, when we were to compare minimally invasive versus open type of procedures, and this is something that is constantly being contested in symposia, conferences, forums between spine surgeons, I would say that this is still something that is left unanswered. We continue to accumulate data and to find which is superior. At this point, there is equipoise between both open and minimally invasive type of procedures. Here we have one of the most well-read spine journals. And in this article is that asks the question, is minimally invasive fusion technologies associated with improved outcomes? The authors here conclude that in both unadjusted and propensity-matched comparisons, minimally invasive versus open technologies were associated with equivalent return to work, patient-reported pain, physical disability, and quality of life at 3 and 12 months follow-up when they were compared to open procedures. In this article from 2017, the authors concluded that the lengths of hospital stay, blood loss, lower surgical site infections were better in minimally invasive TLIFs. However, minimally invasive TLIFs were also associated with significantly higher intraoperative radiation doses, a shallow learning curve, longer operating times, and more frequent implant failures, cage displacements, and therefore return to the operating room for revision procedures. And finally, in this article, when comparing percutaneous endoscopic lumbar discectomy procedures, the authors concluded that when comparing to open procedures, there was a relatively lower success rate and satisfaction and higher rate of post-operative long-term chronic low back pain and possibly of reoccurrence. Therefore, what's the right surgery for me? Most importantly is to discuss this with your spine surgeon. Everybody is different, every pathology is different, and therefore the indications for a surgery are different. Again, the purpose here is to match the patient to the surgery and not have the patient decide or try to select from surgical options what is the best, what they would like to have. Again, the spine surgeon, our job is to direct and guide the patient to the best possible outcome. And again, most importantly is to treat the diagnosis, not the imaging studies. Make sure that the imaging studies and all other diagnostics have been well correlated. And as I tell my patients, you want to exhaust all non-operative treatment options before surgery is considered. That concludes our talk. I will now field any type of questions from the audience. First question is, if we are just starting to have symptoms, who do we see first? If this is the initial symptoms of back pain, again, many factors can be contributing to this. I would say the first person to see is your primary care provider. The primary care provider at that point will be able to direct you to the first line of conservative treatment measures, which will typically include some form of physical therapy. Imaging will be ordered in order to try to find out what is happening. Afterwards, there should be a follow-up with your primary care treatment provider. If there has not been an improvement in this, I would say at that point, the next best line of action is to be referred to a spine surgeon. I guess this answers the follow-up question is surgeon, pain management doctor, or physical therapist. Again, the best first line of defense is the primary care provider. Different primary care providers have their preferences about where they will refer a patient next. Some will prefer to refer to a physical therapist right away, some to a pain management specialist. Seldom is the patient referred right away to a surgeon unless the primary care provider notices or the patient notices that they have a neurological deficit. If there is a neurological deficit present, at that point, my recommendation to patients always is to see a spine surgeon first so that they can be properly diagnosed and treated. Next question I have is, are you in the gateway or do we see you only if surgery is indicated? I would say that I field sometimes patients that are in the gateway as well. And I will recommend them to different conservative managements appropriately, which enables me to follow their progress. And I always tell my patients that if we can get away and not do surgery, then that's great. Surgery, again, should be a last resort and only be done when all other types of conservative treatment measures fail. I feel that sometimes it is an advantage for patients to come and see a spine surgeon, since we are sort of the last stop in the line of spine disease and the last defense. And we're able then to direct the patient accordingly and reassure them that what they have doesn't require surgical intervention, something that can be treated with conservative management, or something that we need to watch more carefully to decide if surgery is actually going to be beneficial. Do we review an MRI before we see you? When patients come to see me in clinic, we do like them to have imaging. We also will see patients without imaging. It is always helpful to have imaging prior to seeing a spine surgeon, since at that point it allows us to be much more effective with the time that we have with the patient, and again, direct the patient accordingly to the next line of treatment. Any other questions? Great. Thank you very much.